Thank you, sir, for the kind invitation. I'll be speaking to you on the submacular bleeds and how do we go about managing them. These are my financial disclosures. When you look at these medium-sized subretinal hemorrhages, I think most of the times we evaluate them using multimodal imaging, as we discussed in the first talk, that if you can get more information out of your angiography and find some specific lesion like a polyp where you can also treat additionally. Otherwise, we give gas and anti-VEGFs, and sometimes we would add laser if there's an extrafoveal lesion. So this is the size of a submacular bleed, which would be quite easily managed using anti-VEGF, gas, and possibly a laser. So an example of that, before we go on to the surgical part, a case like this where you do an FA and ICG, and you can see hot spot which is there. See much better in the early phases of the ICG, which suggests the polypoidal changes, and these we treated with gas, anti-VEGF, and once the bleed cleared, we repeated the angiography and then treated that small lesion again with laser, and eventually had a very good result. So these cases can do quite well with this kind of a management that we see. In the past, we used to do a lot of surgical removals of membranes when the anti-VEGFs were not there, and these are some examples of cases that in the past that we had done. And some of them, especially the younger patients with the subsensory membranes, used to do quite well. But the AMD membranes, because they are sub-RP, they don't do very well with surgical removals. And we had about 5 years back published some data on surgical removals in the era of anti-VEGFs, wherein these eyes were treated with anti-VEGF, and there was already some regression, but to reduce the number of injections, we would go and remove the membranes. Of course, right now, we don't use this approach at all, but just to show you the historic aspect of how the surgery eventually would be based on is about removing these membranes or the blood underlying there. So at that time, we used to make these small retinectomies after clearing the vitreous, and then with a curved forceps, which used to be designed specially for this with a long beak kind of forceps, which would allow us a good access to that plane without disturbing the retina overlying it. And the membrane used to be removed at this stage, and then you would just give a air fluid exchange and position with these. And then, of course, a slightly larger hemorrhages also we used to remove, but that used to lead to a larger retinectomy and used to leave a lot more damage. But still, it was a compromise between lesser damage versus nature, leading to a disciform scar at that stage. So these were also removed along with the membranes, and you would probably achieve results, but with a lot of thinning, destruction of RP, which was there. So recently, with these large subretinal hemorrhages, and now that we have such good instrumentation that we already discussed about, we've been using retinectomy in the periphery to approach it, rather than making a small retinectomy, which would be difficult to manage without using either a TPA or by enlarging it and causing a damage due to the enlargement of this retinectomy. So a patient like this had come with the other eye showing something like this, which obviously meant that he had a similar pathology in this eye, which must have led to a scar like this, and then he had a fresh bleed, and he was extremely disturbed. So at that stage, we had discussed surgical option with them, and we operated the patient with peripheral retinectomy. And here you see we first clear the vitreous completely using triamcinolone to make sure that the whole vitreous, the hyaloid is gone, and then the vitreous attachment is all gone. After that, just to assess whether the perfluorocarbon could displace it or not, you can see how taut this whole area is and how thick the blood is. So eventually we did a diathermy to the whole temporal area, and once we had done that, we cut that area into a large flap, creating a giant retinal tear in the periphery beyond the diathermy mark, so that there's no bleed. And once we achieved that, we everted the flap so that you get a direct access to that plane of blood, which otherwise is difficult. If you make a small retinectomy, it's fine for a small membrane, but for these large bleeds, it's difficult to get access to a plane, and you would end up causing a lot of enlargement of retinectomy. So this is actually a much safer approach, because today the instruments allow us to handle the retina much better as compared to what was there 5 years back. And the gauge is smaller, and the cutting abilities to clear the peripheral vitreous base is much better. So here you can see we have access to the blood, and then slowly, patiently, we just remove all that tissue which is there, and the membrane, of course, along with it also gets removed or debulked from there. And once it's cleared, we again put perfluorocarbon just like you would treat a giant retinal tear, and then gradually fill it up and do a 360 barrage laser at the end and finish the surgery. So this is what you achieve the next day, and this is the pre and the post 1 month picture of the patient, and he's extremely relieved with a 660 visual recovery from almost a hand movements and having already lost the other eye. Of course, there's a lot of RP destruction which is unavoidable because of the membrane's presence in the sub-RP plane that it would lead to, and I think some people are also trying RP transplants from other areas. I haven't done that because I'm not sure, I've not seen results good enough to do all those extra maneuvers at the moment, but we need something more finite for this part of the problem. But if you can debulk it, it's much better. This is another case, a similar case which had turned up, and you can see this is the diagnostics we've done on them, and there's so much blood that you can hardly see anything behind the FA or the ICT itself. And again, we had undertaken a similar procedure where we first debulked the vitreous, removed the hyaloid. This is very important because these cases, if you don't remove the vitreous very well, because you're creating a whole new detachment and retinectomy, it can lead to a lot of PVR if there is vitreous left. So there's more reason to be extra cautious with these patients. And here again you see that we are gradually removing, everting the flap to gain exposure to that particular area. And eventually this is like the whole complex of blood with the membrane which is there. So gradually remove it. Sometimes these membranes are quite tough as well, and it takes a while with the cutter to get through to them. But these new instruments, the new cutters, even though they're smaller gauge, with some persistence you can always get most of this tissue out. So once again it's the same process of putting the flap back and then doing a laser in the periphery like a giant tear. This was the result after that, the pre and the post. And again, these patients are much happy because they have this acute loss of vision when this massive hemorrhage occurs, and it's almost like hand motions. And so they are very relieved to get back that whole peripheral vision, even though they have a central scotoma because of the RP defect. And that's of course something at the moment that we are not able to look at. So these are some of the examples I wanted to share with as of today that we would treat. The medium-sized hemorrhages, I would stress again, work very well with anti-VEGF with gas, and if you can find an extrafoveal leak, do a laser on the polyps, or do a PDT if you have a subfoveal leak. There's no reason to go in for a surgical intervention there. But when you look at these large bleeds, I think we need to look at alternatives, because even the gas anti-VEGFs do not really move this blood as effectively as we see in a lot of cases. Thank you very much.